Thank you, Scott. So I felt really out of place here in the beginning when I first came in, but then I met my two colleagues on either side of me, and I realized that I was more normal on this board than for the rest of the room.
I'm the abnormal one.
Yeah, right. Yeah, and that's saying something. I've spent 37 years engineering complex systems for the Applied Physics Laboratory. A few years ago, my son Michael and his wife Tori both joined Johns Hopkins, and my younger son is also a physician at University of Maryland. We've had a lot of family discussions about how medicine is practiced and about how systems are used in that. And I was always confounded by the lack of what I called integration of the systems and the processes that they used. So fortunately, over time, I was able to be introduced to Peter and start to have this dialogue. So I'm here to tell you a story about how this type of engineering that we've used for many, many years to create complex machines can also be used to help in medicine and to work towards that process of zero harm. What you're seeing in front of you, or behind me, excuse me, is a guided missile destroyer USS Hopper. This has the Aegis weapon system on it. It is one of the most complex and capable warfighting systems in the world. It is composed of hundreds of major systems, thousands of processors, and millions of lines of code. It collects data and source information from multiple sensors, both on the ship as well as on other ships, aircraft, airplanes at sea, as well as land-based systems and spacecraft. It takes that information and puts it together into a picture for the commanding officer. It defends itself and others against hundreds of threats that can come either undersea, on top of the sea, or from the air. And it assists the commanding officer in making split-second decisions, life and death decisions, in spite of overwhelming demands and huge ambiguity. This is a picture of an ICU. It is also a complex system of systems intended to provide care for critically ill patients. It is composed of many systems, processors, and lines of code. It also collects data from a number of sensors and other sources and is intended to provide care and defend against a number of harms. It provides critical information to the caregivers on decisions that need to be made and what actions need to be taken. So what's the difference between these two systems? In the ship combat system, multiple systems were carefully designed and integrated through a disciplined system engineering process to meet specific sets of performance requirements. The intent was to augment the commanding officer, the decision maker, through well-engineered displays and automation to improve the overall system effectiveness and prevent unintended harm. It's a bad day when we shoot down the wrong thing. This has led to extreme performance, availability, and reliability. In the ICU example that you see in front of you, many of these systems present have been designed to individual purposes and have not been carefully integrated into a coordinated set of systems. The overall ensemble of equipment has not been designed to a rigorous set of performance requirements, and in certain situations, even working at cross purposes if they're not correctly configured. The physician and other caregivers need to look to many displays, sources, and other places to get information they need, and in a number of cases, the very critical information they need to make a decision is not easily accessible. This means that the system is dependent upon the individual heroics of the physician to correctly configure the system and to interpret the ambiguous information with little or no augmentation or additional safeguards to prevent harm. The premise, the story that we're here to tell you today, is that we can significantly improve patient care and safety by applying that same discipline of systems engineering to the overall system of people, processes, and things that make up our patient care today. Now, the barriers are not engineering. We know how to do this. I've shown you one example, this example, of something very complex, a comparable complexity to what we have in medicine, and there are very many more like examples. So the barriers are not in that complexity. It's not in engineering. The barriers are in leadership and in the financial investment needed to fundamentally change how we provide patient care. We need to move away from this model of individual physician heroics and move toward an integrated system that augments the physician's decision-making through information technology, automation, and assists in identifying and preventing harm. From the standpoint of somebody who's spent 37 years engineering complex systems like Aegis, and having talked to my son and others about how they provide the care, it's amazing to me that we haven't done this already. There's so many simple, straightforward, incremental improvements that we could make today with immediate reduction in preventable harm. So the paybacks are huge. If we could even reduce a portion of the several 100,000 deaths and uncounted extended treatment periods that are caused by preventable harm, the return on investment would be immediate. Systems engineering, by its very nature, involves proof of concept and test and evaluation of system improvements through data-driven metrics. One such effort, named Essence, has been started at Johns Hopkins under the guidance of the Armstrong Institute for Patient Safety and through a grant from the Gordon and Betty Moore Foundation to significantly reduce preventable harm in the ICU, like you see here. It is through groundbreaking efforts like this that we will be able to prove out new concepts and gather the patient outcome data needed to show the value of systems engineering in healthcare settings. Right back to what Scott says, verify it with data. We are focused on education of healthcare professionals as well in the principles and practices of systems engineering so that they can lead the transformation of patients' care. It's not going to be people like me. It's going to be physicians who understand, who provide this care, and other caregivers who provide this care, who understand the principles of system engineering and employ us to help them do this. The actual application of system engineering will take a multidisciplinary team that have common understanding of the purpose and intent of the system engineering process. Finally, I would like to end on a comment about the concern that automation and decision aids will take away from the autonomy and the discretion of the physicians and other care providers, the so-called robo-medicine approach. Our experience, my personal experience, with designing sophisticated automated systems like Aegis Weapon System says that the opposite effect will occur. If we provide physicians with the highest quality tools to aid them in their decision process and reduce their burden of tracking mundane issues, their performance will increase significantly as they're freed up to start thinking strategically about their patients' care. Thank you.